just as a dilemma to start with, which really just tries to highlight ethics as an issue and why we need to think about it. So back in 1967, there was a philosopher by the name of Philippa Foot, a bit of a moral philosopher, and she kind of presented this problem, which I must admit isn't really directly medically related, but it's just an ethical dilemma where there is this trolley on the left-hand side that's hurtling down some tracks, and if you don't do anything, it's going to run over these people here. Like, it'll just keep going straight and it'll run over this group of people here. But next to you, there's a lever, and if you pull the lever, it would somehow redirect that trolley to a different track, and it will kill one person instead. So this was just a dilemma presented as a trolley problem, and I'm just curious to know what everyone thinks yourself. You don't need to answer. Would you pull the lever such that the trolley moves over and kills that one person, or would you just do nothing and let it run over 5 people instead? In another perspective, if you just think about it another way, supposing that very same trolley was going along tracks and it was going to run over the same 5 people, but instead of a single person and a lever you could pull to redirect the trolley, there was instead this really big person. Sorry, I don't mean to be discriminatory to big people, but there's a really big person standing on a bridge, and you could potentially push him and he could fall on the track. And because he's very large, supposing he could stop that trolley, would you do such a thing? Yeah, naturally, if you're big enough, you could jump off the bridge yourself and block it. But if you can't do that as a supposition, would you be prepared to do that instead? And most utilitarian ethicists may think that sacrificing 1 life instead of 5 is worth it, because the net gain at the end is 5 lives saved as opposed to 5 lives lost and 1 life saved. But the vast majority of people who may have thought that they would save that single person in the first example, in this instance would find it a lot more difficult pushing 1 person off a track, maybe because there's some physical contact and it's a more direct action where you're pushing someone onto the train tracks instead of onto the trolley tracks instead of pulling a lever and just redirecting the trolley. So we can all. So these are really just dilemmas that are faced, and we can't have one rule for one person and another rule for another, just as an illustration, because we should be consistent in our behavior and we should be able to defend our actions, what we choose to do. If I were to give another example, and supposing that single person again was a relative of yours, would you again sacrifice that relative for the benefit of 5, or would you think that, oh, it's my relative, I won't do anything, I'll just let that trolley run over the 5 people instead? And again, that highlights the inconsistency in our thinking generally, that we may act differently in different circumstances, but that's the dilemma of ethics in the first place. Why do we bother about ethics? Because it's trying to do the right thing, and our actions need to be defensible and justifiable based on what we do. If we perform something in our clinical practice, for example, and someone questions, why did you do that? Maybe you could defend it on the basis of, oh, it's evidence-based, that's very straightforward. But some dilemmas aren't really about clinical evidence. They may have to consider many other factors as well. And this is one of the challenges in medical practice, that we have to practice in a manner that is beyond reproach. All of us, doctors, nurses, whatever our roles in the healthcare profession, we are all bound by an ethical code of conduct. So in Malaysia, the Malaysian Medical Council has a code of conduct. In Singapore, in Indonesia, in various countries, they will usually normally have an ethical code of conduct, because these are the core minimum standards by which a doctor needs to practice by. And the same can be said about nurses or other disciplines as well. If you act outside that code of ethical conduct, then in a way, you kind of bring the profession into disrepute, because if a doctor or a nurse acts in a manner that is unprofessional, unexpected of a doctor, then it's basically, it kind of brings the profession down, and then people may start thinking, oh no, oh, if doctors can behave that way, then perhaps we shouldn't really trust them with all our confidential details if they're just going to go out and spew it out to other people and share it with others. So that's really part of the reason why we have ethics conduct to guide our actions and what we do. It's partially to redress the power imbalance because generally all of us on the healthcare side, we have a lot of power in terms of determining management and treatment, and it's to try and give the patient some power as well, instead of the former paternalistic approach of medicine, where in some instances doctors were looked up to as gods, though we genuinely aren't. It's a way of trying to redress that imbalance such that the patients have power as well, and they can say what their preferences and what their hopes and what their wishes are, and we need to respect that as well. The other reasons why we think about ethics is it's really about decision making, because there are many instances in medicine, some particularly unique to motor neuron disease, which I'll share about later, and that really helps ground our decision making and what we do. And sometimes I like to think that, yeah, if positions were reversed, if we were in the patient's chair and the patient were sitting in our chair, and what we were saying to them was almost giving them no choice or cornering them in a way from a decision making perspective, we probably wouldn't feel too comfortable or happy with it ourselves as a patient. So we need to be fair to them, and we need to treat people accordingly how we want to be treated in a way. And I think that's a kind of good starting point when it comes to ethics. So when I was preparing for this talk, I tried to look up the literature a little about medical ethics, particularly in relation to motor neuron disease. And this was back in 1986 by Jonathan Carey from Oxford. And yeah, motor neuron disease at the time was still, I mean, it was well recognized as a disease entity, but some of the practices pertaining to motor neuron disease were being questioned by this author. And some of the things he related to were these. For example, how the diagnosis and prognosis be presented to the patient, if at all. So the prevailing view in that time, back in 1986, was that, yeah, doctors need to do good. Doctors must not crush the hope of patients and must not discourage them in terms of their expectations from a life perspective. And at that time, motor neuron disease, well, it still is actually, it was this horrible progressive illness that just inexorably led to weakness, eventually difficulty swallowing, eating, respiratory failure, and death. And so the doctors at the time thought, gosh, what should we do? What should we tell our patients? And some eminent neurologists from the time even said that, even shared that their way of breaking bad news to patients with motor neuron disease was to say, oh, you have this progressive condition that resulted in muscle weakness. However, after this period of progression, the illness course will arrest. It'll slow down and it'll stop getting worse. And he even went so far as to say, and in some instances, I've even seen patients get better. It may improve actually from motor neuron disease, which was maybe, when we think about it nowadays, it's quite a far cry from our expectations at this point of time, from the perspective of honesty and sharing with patients. What should be done? And that was really the views back in the 1970s and 60s, what the neurologists and others at the time were sharing. And Jonathan Carey also said that maybe ethical principles need to be applied instead of just intuition and judgment. We can't just think, I'm going to tell this patient they've got motor neuron disease and is progressive, going to die. And the next patient, just from an intuition and judgment point of view, treat them differently. So he talked about truth-telling and hope. He talked about deception and placebos, which were commonplace as well, because a patient went to a doctor to expect treatment, and so they'd give them a placebo tablet as treatment for their motor neuron disease instead, which in this day and age, wow, we find it quite abhorrent and appalling. That I don't know, I find it quite surprising to read it, that these were the practices at the time. And that was also the advent of the stage where non-invasive ventilation, other measures were not really established yet. And so there were questions about what were reasonable ordinary measures to treat someone with motor neuron disease and what were extraordinary measures as well. He promoted this idea of prudence, having the correct knowledge about things to be done, having an intellectual virtue whereby a human being recognizes in any matter at hand what is good and evil. And he encourages that we arrive at truths on patients' conditions and relevant materials, particular circumstances. All the pertinent materials need to be considered. And I think this is probably a very good starting point when it comes to ethics in motor neuron disease. And we need to come to decisions based on the patient's condition, all the relevant materials, what evidence is there to support the decisions we're making? What are our clinical goals? What are we aiming to achieve? What does the patient want? Weighing up the benefits, the risks, and being fair to everyone, communicating those things openly. So all the pertinent materials, everything needs to be considered when we're trying to reach a decision in terms of ethical dilemmas in motor neuron disease. I think ultimately we can all agree that medicine aims to help people, and we help people in various different ways, and all our practice needs to be framed around goals, and different goals normally kind of run through medicine in our practices. For example, in some instances, we may aim to cure. So someone with motor neuron disease who has a very bad chest infection, yeah, maybe we can cure that chest infection with antibiotics and physiotherapy and various other treatment to try and improve it. But more often than not, we all know that motor neuron disease is this progressive condition leading to worsening weakness in muscles, in bulbar function, in swallowing, in speaking, in respiration, for example. So in some instances as well, we may think about life prolongation as a goal for motor neuron disease. And the other goal of medicine, broadly speaking, would be to providing comfort, providing palliation, so that people are more at ease and their symptoms are relieved. There are some other goals in medicine, I would add, perhaps education in some instances, perhaps rehabilitation, perhaps disease prevention. But when it comes to motor neuron disease, I think we often dwell closer among these goals instead. And all actions come with costs and consequences. And it's worth thinking about, I mean, everything we do, isn't it? Like Newton's law, for every action, there's an equal and opposite reaction. So for every action in medicine, there are consequences, I guess. If you opt for more comfort, then maybe life prolongation may be sacrificed to an extent. Or if you're treating someone aggressively to try and prolong their life, then some elements of comfort may be lost in the process. And it's just worth thinking about that as well, those consequences, since no treatment currently alters the progression of motor neuron disease substantially. So when it comes to medical ethics, there are just a few key concepts that I'd just like to put across right at the start. The first thing is the doctrine of the sanctity of life. We all know life is precious. More often than not, we seek to preserve life as far as possible. But at the same time, as doctors, as nurses, we all acknowledge as well that life is limited. No one is meant to live forever. We all know that in life, there will naturally be a death as well. So we do need to protect life as far as possible, since everyone only lives once. However, there may come a point of time when life reaches its natural end, and it's important to recognize that as well. Among our other goals as well, and my colleague's going to talk a little bit more about it this afternoon, is the duty to alleviate suffering. Because if someone is suffering, then we shouldn't leave them that way. We should certainly not add to the suffering and make it worse, but we should try to take whatever steps we can to try to relieve it. I'm not saying we can relieve suffering in everyone, but at least we can take steps to see what we can do to make it better. In addition, there's also, I think we all have an obligation to treat people with dignity and respect people. And similarly, again, as mentioned earlier, if we were in the patient's shoes, then maybe, yeah, we should just need to be a bit more careful in terms of what we say to people and how we deal with people, and bear this in mind in the actions and the things that we do. Because at the end of the day, we all wish to treat all people with motor neuron the same, as equitably as possible, as fairly as possible, not offer one treatment to one and another treatment to another, just on a whim, on an instinct. It should be equal across all, although I do recognize that these things are somewhat resource dependent as well. And some countries may not have the access to riches of resources that enable a lot more treatment compared to others. So these things may start in isolation, but I guess at the end of the day, we would hope that whatever is done could be applied across entire countries rather than just in isolation. But these things take time. So I'll just share a little bit about the principlism kind of framework for ethics. I imagine all of you have seen this before, and it was first described by two ethicists, Childress and Beauchamp, and he described four main principles. The first being autonomy, patients having their own choice and right, and I'll talk a little bit more about that in a bit. It talks about beneficence, doing good. Whenever we make decisions, we want to do good for people, and this is good from a quality perspective in that we want, as far as possible, to restore an acceptable quality of life to people, or preserve a certain level quality of life for people, and as well as a quantity of life that is acceptable to them. So it's trying to weigh up those two, that in doing good, we want to try and restore some of those things as far as possible. In addition, there's a duty to do no harm. So that's what non-maleficence refers to, and also a duty for justice. We want to be fair, and that's fair to the patient, fair to their relatives and caregivers, and fair to broader society. I guess we have to be fair to our own medical teams and nursing teams as well. In a way, these things kind of transcend various boundaries, and we just need to be mindful of them in our practice as well. And in addition to these four, there's also this idea of utility, where we want to do the most good for people as far as possible. So rather than treat one person with a super expensive treatment, is that justifiable when maybe tens, hundreds, or thousands may benefit if the resources that went into that very expensive treatment were redirected instead? So that's where utility comes in, and it's kind of something that needs to be considered as well. Autonomy, as I mentioned earlier, is self-rule. This is a definition, free from both controlling interferences of others and from certain limitations, such as inadequate understanding that prevents a meaningful choice. So this was a real challenge for me when it comes to motor neuron disease. And I admit it stems a little from my own personal bias as well, in that I used to see people with non-invasive ventilators, and they used to struggle on them. And I used to think myself that, oh, non-invasive ventilation really doesn't seem to be a good thing to give people. But at the same time, I kind of acknowledge more and more that maybe I'm not being fair to patients. Maybe I'm not really giving them the right information and the appropriate amount of information to guide them to make a meaningful choice. Because if in my own bias, I'm saying to them, oh, we can give you this ventilator, it may help your breathing, but most people don't do very well on it, for example, then I don't think I'm being fair. I don't think that it's really the information I'm giving is free from controlling influences. And to an extent, maybe I'm coercing people in part as well. And doctors are notoriously bad for making quality of life judgments. There have been numerous studies done that show that doctors' perceptions of a patient's quality of life often differs from the patient's own measure of it, or the patient's relatives' measure of it. So we shouldn't be biased about offering these things if we truly want to respect autonomy to people, of people. And it's just important to maybe try to leave our own biases behind, because that influences decisions, and that bias often influences the patient's decision, such that they may, for example, well, I'll talk more about it in a little bit, but patients may be guided more by the doctors based on the doctor's biases. So we just need to be careful of that. So individual decisions. And it's important to recognize as well that individual decisions may have wider repercussions as well, and it may infringe on autonomy of others. So again, as a concept, especially in our Asian setting, sometimes patients even say, oh, I don't really want to make the decision. Ask my relative instead. Autonomy as a construct is a very Western idea, and some other societies may not quite deal with it in the same way, but it's just something to bear in mind. This is just a little bit of food for thought. It's almost a bit of a shock to me as an expression of autonomy, but maybe it's something for all of us to think about as well. So there was this robotics engineer in the UK who believed very strongly that there was a technological answer to most things, and he was diagnosed with motor neuron disease, and he thought a lot and read a lot about the literature and decided that he wanted a triple ostomy for his motor neuron disease. because while he was still well and strong, he thought that I better do all these things preemptively, because if I wait till I'm much weaker and less well, then the doctors may turn me down at that point. So he ended up undergoing a colostomy, having a suprapubic catheter inserted, and having a gastrostomy done, all at the same time early in the course of his disease. And he implored his doctor to write this up as a case presentation, which was a case report that was published 2 years ago. And he described being thrilled with the outcome, and it significantly improved his current and future quality of life. It's a transformation of his life, and he had no regrets as well. So in doing so, yeah, he'd have no issues with his feeding. His bowel care would be perhaps quite simple, just a question of changing the stoma bag, which will make it easier for his caregiver. His suprapubic catheter could be emptied at regular intervals, and he wouldn't need to worry about adult diapers and catheter changes all so frequently. So again, perhaps a rather extreme example, but would we respect autonomy to this degree if we are faced with it in our healthcare settings? Hence, I just say a little bit of food for thought. And just to elaborate a little bit more on justice, I mean, each motor neuron disease, each person with motor neuron disease is a person, and treatment for them may be costly. But I think at the same time, treatments for other conditions are not that dissimilar as well. We spend thousands and tens of thousands and hundreds of thousands on treatment for cancer, for example. But how much is spent on people with motor neuron disease? And they're both, in a way, progressive conditions, especially if the cancer treatments are palliative in nature. And maybe it's not very just or fair from a societal level that MND as a rarer condition gets marginalized as well. It's very tragic as well from a health economics point of view that oftentimes the main measures of what is worth treating is quality adjusted life years or disability adjusted life years, but it kind of almost makes an implication that a life is worth less if someone is disabled, or a life is worth less if the quality isn't there. But again, as mentioned earlier, we are bad judges of quality, and is it fair or right from a justice perspective? And many patients want treatment, but I think at the end of the day, all of them need care. So yeah, how health economics is worked out is a challenge in itself, and palliative problems, especially of this nature, tend not to get the attention they need, and it's warranted. It's interesting as well from a justice perspective that if a patient wants a treatment, what about family members? Can they say no? If a patient really wants to have non-invasive ventilation, I think it's incredibly difficult for a family member to say in front of them, no, I don't want to support your NIV. Maybe they were in abusive relationships. Maybe there has been a history of problems in the past, and this is kind of what I meant, that sometimes decisions have repercussions on others. And are these things fair to society? I don't have all the answers, but it would be good if we can treat everyone fairly across the board, whatever their illness and whatever their condition. So just to go into a few things, especially motor neuron disease related, some scenarios that we encounter, truth-telling at the start, I think that was touched upon already. I'm not really going to go into advanced care planning and capacity in great detail, but may dwell a little bit more on artificial nutrition and hydration, a bit about ventilatory support, and also a little bit about ideas of withdrawal and withholding of treatments, euthanasia, and the doctrine of double effect, because I think they are very relevant in the care of motor neuron disease. There are maybe some other challenges as well pertaining to genetic testing in people with motor neuron disease, and maybe ideas such as palliative sedation, which are very complicated in themselves. So, truth-telling, first thing, again, going back to the original scenario, I think there are probably a lot of things that we need to weigh up when it comes to truth-telling, and looking at each quadrant, nothing really trumps another altogether, but we just need to try and weigh up all the facts when it comes to the values of principalism. So from an autonomy point of view, I think all of us would acknowledge that maybe it's important to establish whether the patient wants to know or not. Because if they want to know what their health condition is, then we kind of have a duty of care to inform them. After all, it's the main patient we're looking after rather than the relatives or others who may be blocking them. And if someone doesn't want to know, then that's fine. We can respect that choice. We can share that if you did want to know more, then please feel free to ask. I'm very open. I'm happy to share any of this information with you. If someone wants to know how much do we need to tell them, some people we want to know everything, including the prognosis and how long they may expect to live. Some people may just be content to know at the start that, okay, I've got a condition that will result in progressively advancing muscle weakness. When do we tell them? Again, it's very individual dependent, and who tells them, it's whoever the person is most comfortable with, I guess. But yeah, I think we would respect their autonomy and share with them what they need to know if there's a desire based on the principle of autonomy. There are benefits to knowing and not knowing as well. I mean, the benefits to knowing, they can think about their condition, they can do more research, they can try and find out a little bit more about the implications of the illness, what treatment options are available to them, how they may prepare for the future. They may think about, saying their goodbyes, planning their life in view of the fact that it's going to get worse, making adjustments to their home, sorting out a will, planning for a funeral, putting advanced care plans in place. There are many things that they could do that may be of benefit if they knew. But again, some people may opt not to know, and there may be benefits to that as well, in that they may just carry on remaining in blissful ignorance, and for some that may be the right thing for them. So that's okay. I think it's just important that when we talk about treating people with dignity and treating people with respect, we give them that benefit of the doubt, and we are open to what their needs are at that point of time. Again, the non-maleficence aspects are, what are the harms from telling? What are the harms from not telling? And it's almost the opposite of the beneficence aspects, I would say, more often than not. So yeah, someone may get very depressed and may be down from telling. That is true. If they've had a history of depression, if they have a history of adjustment problems in the past, suicidal ideations, it may create more problems, and it may raise more issues that need to be dealt with in time. But the harms also from not telling, as mentioned earlier. They can't prepare. Families could live with a conspiracy of silence, where they just everyone knows what's wrong with the person with MND except the person themselves. People can't be honest, can't be upfront with one another. Families may not be able to pull together as much from a point of view of supporting one another and being open and sharing at a time when they especially may benefit from it. And from a justice point of view, is it fair to keep such news from a person? Is it fair to the relative if we decide to tell the person instead of their objections? And is it fair to the healthcare professional that our duty is to the patient, and if a relative doesn't want us to tell the patient, then we just have to consider all these factors as well. And sometimes it's very useful looking at the evidence as well. I mean, what's the evidence for people wanting to know their illness? And the vast majority of people with cancer do want to know what's wrong with them. I'm not sure whether a similar study has been done for motor neuron disease, but it may help us discuss their goals and expectations and think a little bit more about their treatment as well in the longer term. And by informing someone what's wrong with them, then maybe we can plan for future contingencies. If emergencies were to happen, how may they best be dealt with? Advanced care planning is primarily an extension of autonomy for a patient. It's about respecting their wishes and ensuring their care in the future is concordant and aligned with their goals and hopes. As a concept, it's not 100% perfect, but at least it helps us identify decision makers. People can state their preferences of care, and if there are specific actions they wish to decline, if they don't want to be resuscitated, if they don't want to have a non-invasive ventilator fitted, then in the event they did get worse and there was a need for such an intervention, then they could make it very clear at the beginning that I really don't want that done. And our duty would be to respect that. We need to revisit it at times. We need to find out whether that wish is still consistent and remains the same. But by and large, it's an order and an instruction from the patient that we should respect and honor as far as possible. Moving on to artificial nutrition. Again, the main things I have to say about this are just are on this page. What does the evidence say about artificial feeding? I think by and large, where it points to now from my readings of it is that artificial feeding can certainly help maintain body weight or increase body weight in patients with motor neuron disease. In some instances, that it has been suggested that it may improve survival as well. So this goes down to the goal of the patient. Is it important that they live longer with the feeding and maintain their body weight? Or is it their goal that some may opt not to have artificial feeding because they may not want the burdens of having a PEG tube or a nasogastric tube inserted for longer term feeding, wishing to be able to eat and drink naturally and have a more natural death in their eyes. This really would differ by patients. And there are benefits to it, as mentioned earlier. There are perhaps potential survival benefits. There are benefits to their caloric intake because if swallowing becomes more difficult over time, people may find it difficult to meet their daily energy requirements. So the caloric intake is definitely helped by artificial feeding. There's maintenance of weight, as mentioned earlier. It may help address hunger-related issues as well. There are some harms as well, as I mentioned earlier, the consequences to all decisions. So a tube costs money in Malaysia. If I'm not mistaken, I think it ranges between 500 to 1,000 plus ringgit, depending on the type of tube that's inserted. There are complications associated with the procedure, bleeding, infections. There are complications and costs associated with feeds because someone has to buy feeds for the foreseeable future. There may be admissions for issues that arise from the tube, leaking, dislodgements. There may be other complications, diarrhea and care-related issues, because certainly a member of the family or some employed caregiver will need to be engaged to look after these tubes in the longer term. And again, in being fair to patients, yeah, we give them the option. We think about what additional support they may have in terms of looking after the tube, whether it's something practically that is possible as well for them to cope with and deal with in their own environment. And again, thinking about autonomy, bearing all these things in mind, would someone still wish or hope to get the tube done as an aspect of supporting their care if this kind of may add to their survival or this adds to their comfort? So they're all things that need to be weighed up when it comes to artificial feeding in motor neuron disease. Ventilation, in turn, a tricky area. It's almost sometimes linked more with life because it's so closely associated with our own breathing. And if breathing is difficult, it's extremely distressing. So again, non-invasive or tracheal intubated ventilation, tracheal invasive ventilation, the evidence by and large points out that it clearly improves survival, more so in the non-bulbar types of motor neuron disease, at least maybe adding 2.5 years, potentially also having a better quality of life as well. So we know there are unquestionably benefits from non-invasive ventilation, survival benefits, symptom improvement benefits, having more oxygen and better ventilation enables someone to use food more efficiently and generate ATP in the body. And we recognize their quality of life benefits as well. Again, there are potential harms and challenges with it because long-term NIV, people may have tracheostomy or may have NIV or tracheostomy. Sometimes speech may be a little bit more difficult. You may have to explore other means of communicating, be it by writing, light writers, eye trackers, other means. And I guess it's important to recognize as well that it can support the breathing, but this will be on the background of worsening function and impairment. So many of the historical ethical documents or papers written about NIV describes people being locked in, maybe only able to move their eyes, unable to move their arms and legs, and just bedbound connected to a machine. So it was a strong discouragement against NIV before. But as I said, that may be our own biases. We had a lady who once didn't want NIV or I was led to believe she didn't want NIV. In the end, she ended up admitted and intubated and ventilated and had a tracheostomy put in. And when I asked her years later whether she was okay with it, she said she was fine. And she couldn't move and she couldn't do anything. And on one hand, as I said earlier, we can judge her quality of life as maybe not being so good, but in her eyes, she was fine. And so after that, I thought, okay, if people are okay with that, then I need to be okay with that as well. I shouldn't impose my own expectations and views on others. And again, from a justice point of view, there is bound to be a substantial impact on a household of someone with MND. Finances, a huge amount of care will need to go into looking after someone with NIV. Someone may need to give up their career, someone may need to give up their social life and everything else they want to do in trying to provide care for someone with MND, unless there's more respite and support available in the community. Is it cost effective? I guess that's something that needs to be explored further. And what happens if someone has no caregiver? Does it mean that we deny them something that may be beneficial? Is there room to explore whether they could get caregivers instead? Or is someone like that kind of disadvantaged simply because there's no one else around to look after them in spite of a wish or desire to live themselves? So these are all challenges, and as I said, I don't really have easy answers and they need to be judged on a case-by-case basis. So what would someone with MND want? What would the relative or caregiver want? And many relatives and caregivers, when surveyed in the past, I think 90% of caregivers were happy for their loved one with MND to have the NIV, but most of them would wish not to have it themselves, which is quite interesting because they were happy to support the caregiver, the relative from the looks of it, but for they themselves, they didn't seem like they wanted a life with an NIV machine. And I guess it's important to judge also what can the healthcare team provide and support effectively, because if we're under-resourced to do it, it's extremely difficult to look after someone with MND well. So when it comes to MND as well, the other things that I wanted to cover very briefly were the withholding and withdrawing of treatment. This varies very much by country and everywhere is different. By and large, I would like to say that all medical interventions, be it antibiotics, ventilation, artificial hydration, artificial nutrition, these are all medical interventions. So the decision to prescribe them or commence them are very much medically driven. We can talk to patients about it, we can explain them in detail, and but at the end of the day, and the patients can choose to accept it or refuse it. But at the same time, there may come a point of time as well where it may be considered to withdraw or withhold certain treatments. So for example, if a patient on NIV says, I really don't want this anymore, it's not really compatible with a life that I expect and hope for, then from a medical perspective, it is acceptable to withdraw it. The patient needs to understand, obviously, the consequence of withdrawing it and that they may get worse, but the obligation on the medical side is to make sure that if we do stop the NIV, we need to take appropriate measures to maximize their comfort as far as possible. If the medical intervention, again, is deemed to be disproportionate, and that's an ethical term to mean that the risks outweigh the benefits, it causes more harm than good, then we may choose to withdraw a medical intervention as well. Likewise, if something is deemed futile or potentially inappropriate in achieving the goal that a patient expects, then it would be acceptable to withdraw or withhold it. This practice very much varies from country to country. There are some countries like Japan, as far as I know, where this is not accepted as a practice. In Malaysia, certainly it is described as permissible within the MMA Code of Medical Ethics, and Fatwa Malaysia also said that this is an acceptable practice in 2011. Cessation is permitted if there is no chance of recovery, and they deem this to be not the same as the practice of euthanasia. So in medicine, in practice, all therapies may be started, all therapies may be stopped as well, especially if, again, patient refuses, it is disproportionate, or it's not really achieving a goal a patient wants. But it's extremely difficult. I don't deny that this is it's quite a heated idea and concept to some. an attempt for me to define euthanasia, because some people may think, oh, if someone is dependent on a machine and you stop the machine and they die as a result of that, are you not euthanizing the patient? So just for a definition, it's a very challenging area as well, because if you look up on the internet or anywhere, you will read many definitions of euthanasia. You will read about active euthanasia, passive euthanasia, voluntary euthanasia, non-voluntary euthanasia, involuntary euthanasia. There are many definitions. And I think the challenge is no one has really tried to define it properly. All euthanasia means is a good death. That comes from eu and thanatos in Greek. So the EAPC tried to resolve this, or tried to put forward a proposal. That's the European Association of Palliative Care. They said euthanasia is a doctor intentionally killing a person by the administration of drugs at that person's voluntary and competent request. So someone free from influence, free from coercion, making a request to end their life. It's competent in that they're very clear in their mind, they're not depressed, they're not influenced by other psychiatric disorders or problems, requesting the doctor to kill them. That's how the EAPC tried to look at it. But as I said, it's a very gray area, because even years ago, India ruled that withdrawal of treatment was passive euthanasia, which again adds to the confusion and the complexity. But they legalized it because it was a case of someone having a treatment stopped and were possibly going to die as a result of that. So from an ethical position, for an act to be euthanasia, the intent, what we hope to do, what we aim to do, is to kill the person and end their life. It has to come from the patient. It's a request of the patient, and the action that's taken to end the life, the action that's taken is to end the life, or at least the desired outcome is death in the patient, and the action taken is the cause of death in the end. To try and distinguish it a little from withholding and withdrawing treatment, in withholding and withdrawing treatment, our intent more often than not is to try to reduce the burden or remove an unhelpful intervention, or not to start something altogether because the patient may have declined it or refused it through their own voluntary point of view. So someone can refuse treatment. That's not really euthanasia, because the intent is different from the intent in euthanasia. Withdrawing and withholding treatment may be initiated by a patient if they request it, or it may be done in the best interest of a patient if the care that we're providing is not consistent with the goal that they're hoping for. The action is often not with the desired outcome is not really death. Sometimes what we do may be done to reduce suffering or to respect wish. If the patient does not die, that's fine. And not all withdrawals of treatment may result in death. Someone who is not eating or drinking very much and has a PEG tube in, decides he doesn't want to have feeding continued. Maybe that's not a very good example. But if he stops feeding through the tube, he won't die instantly as a result of that. May still manage some oral feeding, for example, and that's okay. We don't want the patient dying. We're just stopping a treatment that he doesn't feel is advantageous or consistent with the goals of the patient. And in withdrawal and withholding treatment, death is usually from the underlying illness. If someone has motor neuron disease that is ventilation dependent, stopping that will result in death. Stopping ventilation will result in death, but the death is caused by the underlying illness or condition when you withdraw and withhold the treatment. So we don't believe certainly that withdrawing and withholding treatment is the same as euthanasia, and it does seem to be acceptable practices, an acceptable practice in many parts of the world, although I accept as well that in some parts of the world, and this is very kind of socially and culturally defined as well, some countries may not accept this for religious reasons, some countries may not accept it for cultural and social reasons, as mentioned earlier. So I'm going to finish shortly. I just want to touch very briefly on this doctrine of double effect, because it's something very closely often described in palliative care circles and maybe relevant in motor neuron disease as well. So killing one's assailant is justified provided one does not intend to kill him. Nothing hinders one act from having two effects, only one of which is intended while the others is beside intention. So when you defend yourself, sometimes you may kill someone by mistake, but that was really a mistake, not your intention to kill them. So accordingly, the act of self-defense may have two effects. One, the saving of one's life, the other, the slaying of the aggressor. And yet, though proceeding from a good intention, an act may be rendered unlawful if it be out of proportion at the end. So you're kind of in defending yourself, if someone dies by mistake through the act of self-defense, because you didn't intend to kill the person, it's not like it's murder, or because you never intended to kill them in the first instance. So an act may have a good outcome and a bad outcome potentially. And I'll just try and describe this more in a palliative care sense. So in the context of an action that has both good and bad effects, doing an action that has a bad effect is permissible if the action is good in itself, if the intention is solely to produce the good effect, if the good effect is not achieved through the bad effect, or there is sufficient reason to permit the bad effect. So where this is often thought about is, for example, if someone has, let's say, very severe breathlessness, and you want to palliate that breathlessness potentially, they refuse non-invasive ventilation, and we're thinking about something pharmacological to help. So oftentimes morphine is described in this setting, that giving morphine to someone who is really severely breathless, we have the intention to relieve the breathlessness with the morphine. So our goal is to try to make them less breathless by giving them morphine. We know morphine can potentially cause a degree of respiratory depression as well. But the relief of breathlessness is effected through the use of morphine. The intention is that the palliation is not effected through the respiratory depressive effects, rather the effect of morphine itself. So we would normally think that it's reasonable to give someone morphine, even though it may have a bad effect, because our intent is to try to produce the good effect of morphine, palliate the breathlessness, make someone feel less breathless. And titrated in low enough doses, we don't expect the bad effect to occur or have a significant impact at all. So this is really something that we use in palliative medicine as a justification for some of the actions we take. Safe titration very rarely, if ever, leads to death, for example. But sometimes people are scared to give patients morphine because they're worried that, oh, if I give the patient a morphine and they die, then I have killed them. But the doctrine of double effect is a way of protecting medical staff from an ethical perspective, because you're doing it for the good effect itself. Your intention is to produce the good effect, and the palliation of breathlessness is not achieved through the respiratory depression. This is a very common practice, so it generally is acceptable, and it's something that's practiced commonly. So I kind of share it just to say that stuff, if used safely in a measured way, it's reasonable to give people morphine in this context, or other palliative care drugs in this context, because it's the good effect that we're after, not the bad, and we're not achieving the good effect through the bad effect of the drug. Just a few other things. Oftentimes ethical dilemmas result in conflicts and clashes of principles. And it's important to take everyone's point of view. Listen to the healthcare professionals, listen to the individuals, listen to the family, think about broader society and the impacts and the consequences on them. Because we're often trying to balance autonomy and social justice and futility, among other things. It's really, really important to be very clear what goals can be achieved in the people we're looking after and what the evidence underpins it. And engage everyone, because we need to take all perspectives in order to reach a shared decision. Sometimes ethical dilemmas are not really ethical dilemmas, but they're communication problems, because certain things haven't been communicated clearly and effectively enough. It may help sometimes that if people wish to have more treatment or ongoing treatment, we can establish ceilings of treatment such that, okay, I can carry on the treatment, but if it reaches this point, then maybe we just need to take a few steps back. And the last thing is just speak to others, clinical ethics committees if your hospital has one, or other people who may be interested in ethics to try and resolve some dilemmas. So as a very quick summary at the end, try to remove all personal bias and judgment. I've certainly had to reflect on that myself in thinking about the care of people with MND. Provide choice to people, reasonably acceptable options, because it's only through that choice that people can make autonomous decisions. Never, never, never make anyone feel that their choice is wrong. They're already in enough kind of difficulty and stress and distress, and being questioned about it will only make them feel worse. Apply the principles, principlism, other approaches to ethics to try to resolve issues. Be prudent when it comes to making decisions. And if in doubt, like I said earlier, try to discuss the dilemma with others. It may make it easier as well. Just a little bit of further reading if anyone is interested. There was a very good review by Seltzer, the first one here, which talks about full spectrum of ethical issues and almost a framework of good care for people with MND. So they looked at all the different things that may contribute towards good care in MND and the ethical issues entailing it. And there are a few other things about considerations and aspects about patients wishing to die in ALS scoping review.